I promised you that I was going to tell you my story, and here it is. I'm 38 years old. For as long as I can remember, I have always wanted to be a mom. More than 5 years ago, my husband and I had just decided we can do this now. So we tried for a year, and then I finally got pregnant. It was an ectopic pregnancy. At that point, I had to have 2 surgeries, and I was very sick. I have had 3 more miscarriages. The most recent one was earlier this month. When I was about 8 weeks along, I went to the doctor to have an ultrasound, and I was told that it did not have a heartbeat. It was absolutely devastating. When I shared my story with you, many of you also shared your own stories. Somebody wrote, "This hit home. I had a miscarriage at 27, and although you will recover physically much quicker than mentally or emotionally, you'll get there." Somebody else wrote, "I went through the exact same thing years ago. I got pregnant 3 months later and had a beautiful baby girl. It's not going to be easy, but give yourself the grace to heal emotionally and physically." And finally, I'll share this comment. "I lost my first child only in the first trimester due to miscarriage. I couldn't believe how many of the women in my life had experienced this and had never talked about it. But we're talking about it today. We're going to be here to answer your questions, share some advice, because you should not suffer in silence." Good evening, and thank you so much for joining us tonight. I'm Stephania Jimenez. We are joining you live from the KSAT newsroom to talk about infertility and pregnancy loss. This is a very special town hall event. We want you to take advantage of the space so that you can get the information that you and your family need or want about infertility and pregnancy loss without fear of judgment. Now, come on over with me, because we have 2 very special experts joining us here tonight, and they have heard it all in this arena. First up, we're going to start with Dr. Gregory Neal. And I'm reading from my paper because, it's a long title. He's a board-certified reproductive endocrinologist and obstetrician with the Fertility Center of San Antonio. And Dr. Neal, you've been helping women and families with fertility issues here in San Antonio for 30 years. So we're glad to have you with us. And here we have Ashley Vatswaviak. She is a licensed clinical social worker with AW Wellness in San Antonio, and she specializes in reproductive and perinatal mental health. Welcome to you both.
Thank you.
So first, I'm going to start with you, Dr. Neal. The easiest question maybe, but one that we can it's a really good jumping off point. Okay. What exactly is infertility? How do you define that medically?
Medically, it's defined based on age. And so infertility for women under 35 is defined as trying to conceive for 1 year without success. 35 and older, it's defined as trying to conceive for 6 months or less. Or 6 months, at least 6 months, sorry. And so basically that's when we recommend, coming for evaluation. So you've been trying for a year and you're under 35, come for evaluation. Been trying for 6 months without success, come for evaluation, so we can see if we can figure out what's going on.
Now, we know, I was reading some statistics, something like 15% of men suffer from infertility. Ashley, you speak with families, you speak with couples when they go in and they've had trouble getting pregnant, or they have fertility issues. Can you break down how that affects a person psychologically, mentally?
Well, absolutely. I think it's beautiful that you're bringing light to both grief and how this affects people emotionally. Infertility is something that is different. It's a different type of loss. When there's a loss in the community or the general world, typically a death, that is something that's recognized. We're mourning that relationship. There's a burial, there's a memorial. But with infertility, grief is a little bit different, and loss is different, and not necessarily is there a death. It's what we call disenfranchised grief. It's something that can be very silent, and something that oftentimes society doesn't recognize or even know it's even occurring. So it can be life-changing. Receiving an infertility diagnosis can be quite comparable to receiving a cancer diagnosis. is really life-changing in many ways.
Yeah, and people don't usually talk about it or because they don't feel comfortable talking about it. And that's exactly why we're here tonight, to break the stigma, to make sure that people know that there is help out there. There are treatments for you, and you can also get mental health help if that's what you decide that you want. Okay, now we want to go to our viewer questions because many of you sent those in, and we want to make sure that we get you all of the information that you need. First, we're going to start with one question from Jennifer. Let me just tell you a little bit about Jennifer. She's 38. She has stage 3 endometriosis, which can, of course, affect the ability to get pregnant. She had an unsuccessful IVF treatment last year. Jennifer, I'm sorry to hear that. She says that her doctors tell her it's easier to get pregnant in the second round of IVF. So, Dr. Neal, she's asking, what complications could I experience if I were to get pregnant?
Well, there have been some things that are a little bit more frequent with somebody that's got endometriosis. They can have increased risk of miscarriage, for example, increased risk of miscarriage is one of the things that you wouldn't really think of necessarily that would happen with somebody. Preterm birth is another one. Increased risk of C-section is another one. So there's several things that can be associated. The biggest thing, though, is that any of these things that can be slightly increased with endometriosis can also be managed by an OB-GYN. So it's not a reason to say, oh, I've got these little increased risk, I better not try to get pregnant because it freaks me out. Well, these are managed by an OB-GYN doctor during the pregnancy. These are managed by a maternal fetal medicine doctor. And so from that standpoint, it's something that's slightly increased, but it's very manageable, I would say.
We also talk about what are the signs or symptoms of miscarriage, because from reading a lot of the comments that people sent to us, some people said that they were having a miscarriage and they had no idea, and there's that guilt or that feeling that had they gone to the doctor sooner, maybe that pregnancy, that baby could have been saved. What are some things that women experience when they're pregnant, when they're miscarrying, where they need to get attention right away?
Well, the most common thing is that women will start having bleeding in the first trimester. And so, as far as when we help couples get pregnant, we follow them through the first trimester of pregnancy. So we see, the different things that can happen. So bleeding is the most common thing. It's actually called a threatened miscarriage when somebody presents with bleeding during the first trimester. We also have plenty that come in, everything looks great. And then the next time they come in, there's no heartbeat. In the first visit, there was a heartbeat, and they don't feel any different. Some women actually do feel loss of pregnancy symptoms, and they'll call me and they'll say, well, I know I had a heartbeat and everything looked great, but I don't feel pregnant anymore. And then they'll come in, and interestingly, it's not always, worst case scenario. Sometimes they're just getting past those first trimester symptoms a little earlier than getting out of the first trimester. So those are some of the things, that we see.
But calling your doctor is never a bad idea.
No, it's never a bad idea. And honestly, you can't really control it. I hear so many times women beat themselves up. If I had only done this, if I had only hadn't done that. And if it's going to happen, typically it's going to happen. So I always try to reassure women, because they really take it hard. And obviously in miscarriage you take it hard, but don't make it harder on yourself thinking that you did something, because generally it's just going to happen.
That leads to our next viewer question. This is question number 2. This person asks, I unexpectedly got pregnant immediately after a miscarriage. I'm now 33 weeks and still think of the baby that I should have by now. How can I balance grieving a loss while also feeling joy for the baby that's going to be here in a few weeks? Ashley.
This is so common, and the answer in short is that you will never forget, but in the moment and in the process, it doesn't feel that way. It can be a great struggle for many families. I think ultimately,
so you're saying that it can be a struggle for a lot of families, and And it's a balancing act, is what it seems like.
I think the biggest fear is of ultimately forgetting, and sometimes there can even be a fear of betrayal, that if I love this new baby, does that mean that I've been forgotten or don't love the first baby? And ultimately, I think the goal is to synthesize both experiences as unique and distinct parts of your family story, and that can take some time.
Yeah, time is what we need.
Right.
Okay, Dr. Neal, we're going to our next question here. Is there a link between obesity and infertility? And I'm going to add something else to that, and how about for men? But let's answer the first part first. Is there a link between obesity and infertility?
Yes. Do you want me to expound?
Sure.
Basically, the most common thing that we see is ovulatory dysfunction. So that's a medical term for not ovulating as frequently. And as a woman's body mass index increases, that becomes more significant, to the point where some women just quit having periods altogether. So it is definitely common, and it's been shown that if women have even moderate, or not moderate is a bigger word, modest weight loss, that their menstrual cycle irregularity can improve. And whether that's through lifestyle modifications, such as diet and exercise, using medications like tablets or pills or something, getting bariatric surgery. There's really good literature in bariatric surgery showing that menstrual cycle regularity improves quite a bit. So it's definitely something that we see. So these women oftentimes have to come for fertility treatment because they're so irregular. A big subset of women who have high BMIs are women with polycystic ovary syndrome. And
Yes.
so, but it's not one and the same. I mean, not every person who's overweight has polycystic ovary syndrome, but a good proportion of women with polycystic ovary syndrome are obese.
Overweight. How about for men? Is there a link between obesity and infertility? We gave you that stat earlier about 15% of men being infertile. Is there a link for them? Because so much focus is always on the woman and the woman's health, but
Right. So overweight men, especially significantly overweight men, it typically will affect the semen analysis. And so it's just hormone levels. And so men will have to, also undergo some lifestyle modifications a lot of times just to try to lose weight, and then they'll see their semen analysis parameters improve.
Can we talk about that? Because so much of the burden is often on women when we're trying to conceive or have a child, but there are things that men can do as well. And I'm just wondering what your experience is in dealing with all of your patients.
In terms of fertility challenges?
Yes. It being sort of an equal thing where the onus is not just on the woman.
Absolutely. Men deserve just as much support as women, and it does seem that we have a lot more support for women. But mental health doesn't discriminate, grief doesn't discriminate, and neither does infertility. There are a lot of support groups out there for men, and for, in particular, male factor infertility. And any mental health provider trained in this area is open to working with not just women, but males or anyone, no matter how they define their gender.
Okay, thank you. Now, Dr. Neal, we're going to our next question now. Why does using frozen embryos not result in a successful pregnancy and delivery? This person who is asking this question says that she lost her twins while she was 21 and a half weeks pregnant. I'm sorry to hear that.
Yes, my condolences too to hear that. That's horrible to get to that stage of pregnancy and lose it.
So far along, yeah.
So far along. And well, basically, it depends on what you're defining as success. I mean, obviously live birth is success, and so having a loss at that time, she must have had a frozen embryo transfer at that point. When we've looked at our statistics, though, from frozen cycles and fresh cycles, it's really interesting. Like in the last 4 years, and all IVF statistics are based on the age of the female. So they're classified as under 35, 35 to 37, 38 to 40, 41, 42. And so we've looked at our statistics, and some years the fresh rate under 35 is higher than the frozen rate, and it's not that different. It's interesting. It's not really that different. And then 35 to 37, 1 year I'll see, oh, the frozen rate was higher this year. Oh, that's interesting. So frozen embryo transfers, and they're becoming more and more common because when we do IVF, we are doing a lot more pre-implantation genetic testing for aneuploidy. Aneuploid means abnormal chromosomes. And the abbreviation for that long mouthful is PGT-A. So that means we do IVF, we get embryos, specifically blastocysts, which is an advanced cell stage, take a few cells out of that embryo, freeze the embryo, and send the cells for testing. Well, now we have frozen embryos. And so as this technique has evolved over the years, we're doing more and more frozen embryo transfers. And so really, I don't see frozen embryo transfers overall as a negative. They're very common. We do them every day. It's just that this one didn't, unfortunately didn't work out. It does bring up, the twin issue, is important because twin pregnancies, are significantly more, higher risk. And it's a reason that we routinely put back a single embryo. So it's a single embryo transfer. The term now is actually elective single embryo transfer, ESET or ESET. And so it's because of the risk of twins. And what's allowed us to be able to go to elective single embryo transfers because the pregnancy rate for single embryo transfers versus double isn't that much different. But we go from a 0.5 to 1% twin rate with a single embryo, and that tells you that the embryo can split. It happens several times a year to us. Instead of the twins, where the pregnancy rate may be a little higher putting tube, but now you got this twin rate that goes, way up here. And so that's one of the things that's happened over the years. And the nice thing about improvements in IVF success is allowed us to go to the single embryo transfers.
Well, I hope that whoever wrote this is getting the help that they need. I just keep going back to the 21.5 weeks. That's devastating. Ashley, what advice do you have? I want to go back to partners. What advice do you have if there's a couple and they're going through this loss and the woman is going through it physically, emotionally, but if you're watching your partner go through this, what can you do? You must feel helpless. What can you do to help them and to help yourself, because you're also dealing with loss?
Yes. I think loss of control is probably the central emotion experienced by a person going through infertility, especially if they're struggling more on the emotional side. And can you remind the question?
No, just about when your partner is going through this loss and you're watching it happen. What can you do?
It's common for not everyone to grieve in the same way, and sometimes initially couples will really join together, but then sometimes one partner needs a little bit more time, and they might find that one partner is pulled away. Oftentimes I can see maybe a couple and maybe one partner is holding back their emotion because they don't want to add in any additional distress to the other partner, but that can really create a rift in the relationship too, because the other partner then feels all alone with the emotions and can really even question their experience, they're experiencing. So anything to open up lines of communication, to check in on each other, even daily, and just to process where they are, how they're feeling, what they can do for each other. I think could be very, very healthy and healing because it affects each partner differently.
And it also gives the other person a chance to be there for that other person as well. Here is a question that I have for both of you. You mentioned PCOS just about a few minutes ago. This person writes, I have been diagnosed with PCOS and am overweight. The doctor tells me that I need to diet and exercise, but it feels hopeless at times and leads me to depression. The holidays and even being around family with children can be triggering. It makes me feel alone and is embarrassing. Any advice? This person is 24 years old. I'll start with you, Ashley.
The first thing that stands out with that is just the depression. And absolutely, if someone's experiencing an extreme amount of depression, having difficulty getting up and facing the day, difficulty functioning at work, experiencing social withdrawal, changes in their sleep or eating habits, not finding joy in things that tend to bring them joy, I think reaching out for support in that area can be helpful, because receiving a diagnosis that might compromise future fertility can be just devastating to cope with. And then on, you can remind me.
No, she just, well, it was a long, it was
I think it was two-pronged here.
Yes, yes, she
there was
says,
the depression,
she says
and then
the holidays, and even
yes,
being
the
alone,
holidays
around family can be triggering.
are upon us, and navigating the holidays can be hard, aside from experiencing a reproductive loss or experiencing infertility. I always ask patients, what is it that you want to do? Do you want to go to the holiday party, and or is this something that you feel pressured to do? And to really do what they want to do, and that can actually be very healing in their grief process. I think another thing that can be helpful is if one partner, if you're wanting to go to a get together, if one partner reaches out in advance, maybe to the host, to let them know that, if we could avoid all questions around pregnancy or what our plans are on our fertility journey, that would be really helpful if we can just avoid that. And that can kind of take that out of the picture. And then if you do decide to go and someone asks the question that makes you feel really uncomfortable, to come up with a saying before you go to the party, that really just sets a boundary of saying, thank you so much for asking, but that's really a hard thing to talk about right now. And you can even role play that with your partner before you go.
That's a good idea.
PCOS, that adds another layer sometimes of complexity. When we're talking about fertility, this particular young woman is 24 years old and has PCOS. Obviously, you're not seeing her, but what advice, how do you usually treat people who have PCOS and do want to get pregnant?
Well, if they're ready to get pregnant, the most common thing that is with PCOS patients is their inability to ovulate. And so I talked about it earlier when we were talking about obesity, but that's one of the hallmarks of polycystic ovary syndrome is irregular cycles. I mean, there's really three things that we look at in diagnosing somebody. Irregular menstrual cycles is the first thing. Elevated androgens or male type hormones is number two. And then number three is ovaries having a characteristic appearance on ultrasound. And you have to have two out of those three to come up with the diagnosis. And so, I mean, some patients go to their OB-GYNs and they have irregular periods and they tell them they have PCOS. And, so they come see me later and I'm saying, oh, you've got the opposite of PCOS. You're running out of eggs. And they just guessed. And they guessed wrong. Glad you're here now so we can maybe do something about it. But in general, I mean, we see a lot of patients with, with polycystic ovary syndrome. And when they're, ready to get pregnant, the first thing that we do, we do some testing, to prove that they have polycystic ovary syndrome. So, we draw an androgen lab panel to see testosterone is elevated in men really high, but in women with polycystic ovary syndrome, it's elevated. The higher it is, the more excess hair growth they have. And so do an ultrasound to confirm, yep, ultrasound characteristic appearing ovaries. And so now you do have the diagnosis. And then we can go into treatment. So the main treatment to start with is called ovulation induction. That means giving a patient medication to get them to ovulate.
Got it.
And so, once they're ovulating, now they got a shot to get pregnant. Before, like women with PCOS, you can have no periods. My most severe patients never have a period unless they go on a progesterone pill for 10 days, they stop it, and then they get a period. Some have, 2, 3, 4 ovulations a year, but they don't know when it's going to happen, right? And the egg only lives 24 hours when it's ovulated. So you got to get really lucky to get pregnant. I mean, I have those patients who show up and I say, really? You hadn't had a period in 6 months and had a positive home pregnancy test? And so it happens, but most of the time they have to come and then we have to, put them on fertility medicine. Used to be Clomid was the #1 drug. Now it's Letrozole, which the other name is Femara. Seems to have a higher live birth rate, so we tend to use that medication more frequently now. So that's where we're at.
Okay. Now, we've talked about a lot of women who have suffered from pregnancy loss, assuming that they get to that point where they get that positive home pregnancy test. But what about the women or the people who are struggling for years to get pregnant and they just can't? Ashley, what advice would you have for them?
It can be just utterly heartbreaking to get to the point, especially on a fertility journey, of realizing that you're not going to be a parent or not going to have a child. And there is a lot of support out there for infertility patients that become childless not by choice.
Yes.
And grief is lifelong, and there's no race to the finish line. It can take a long time to process and incorporate that into someone's life story and make sense of that. But there is a lot of support available, and support groups. And
Yes, there's actually a list of those support groups which we have on our website right now, and we will get to that towards the end of our chat. Now we have another question for Dr. Neal. This person asks, I had a miscarriage almost 3 years ago and haven't been able to get pregnant since. I'm 34 now and worried that it may not happen again naturally and time is running out. What's your advice?
Come see me. No, and it goes back to the definition of infertility, and it kind of ties into the last comments that you were making. So if you're trying more than a year and you're under 35, right? That was the definition of infertility. Don't wait to come in. See, there's that sense, I got pregnant, so I'm going to get pregnant again. Well, you don't really know what might be going on. And so you get to that year point, come see me. And I have patients who say, well, I'm not going to do IVF. I don't believe in it, it's too expensive. Well, come in and at least get tested so we can at least tell you what's going on. I mean, that's the first step. And then with education and knowing what's going on, then we can talk about, okay, you don't want to do IVF, well, we can do something simpler. We don't have to jump to
IUI?
We can do IUI, intrauterine insemination with partner sperm time to ovulation. Yeah, we do that all the time. But I just encourage, the thing that's is frustrating for me doing what I do and love what I do is that I see a 38-year-old who's been trying for 6 years. And I would say, if I could have seen you at 33 or 34, we would have had a much better chance of getting a baby. And then they're diagnosed with diminished ovarian reserve, which is a stage of reproductive life all women go into. It's between normal ovarian reserve and perimenopause. Women are in the stage 8 or 10 years, and you don't know you're in that stage unless you get tested. You're still having periods every month. And so that's why I just, part of this, I hope I can appeal, couples, okay, at least come get tested. You don't have to do any treatment. Have some peace of mind and say, okay, this is what's going on, and okay, thank you, doc. We're going to keep trying on our own, or thank you, doc. We better get on the stick, and get after it. So.
Right, because that's the thing too when it comes to bringing a child into this world. I always say, children are a blessing, but they're also a huge responsibility. And so for so many people, they want to get their careers on track. I'll use myself as an example. I wanted to get my career on track and make sure that I was stable in one place. And unfortunately, I'm to the point now where I'm 38, and if I do have a child, it's going to have to be with medical intervention, and so that's why it's so important to have this conversation. And
I'm sorry to interrupt, but it's also a very common thing that we're seeing now. Women are prolonging their careers, and then they come in and try to get pregnant later. But it's interesting because some of the big companies like Amazon and Google, they started covering egg freezing.
Okay, we're going to get to that in a moment. We're going to get to that because I know you're excited to talk about that. Okay. This is one of our last question actually, and it is, why aren't insurance plans required to cover fertility treatment in Texas?
Okay.
And you're saying they are, but.
It's so interesting. So there are mandated states like Massachusetts where infertility is, the state says it has to be covered, the insurance companies have to cover it. In Texas, the difference is the state says the insurance companies have to offer it. But the employers don't have to pick up the fertility rider. So you'll see that these companies, they do offer it, and they have to offer it by Texas law, but they don't routinely pick up the rider because the insurance is so much more expensive. And so, but there has been a little bit of a shift. We are seeing more companies that offer IVF coverage, for example. It's the most expensive thing, and so that's when somebody sees that it's available. I have patients who are working for companies just because they cover. I have a guy who's working for Amazon I have another patient who's working for Starbucks because they offer it. I have another patient with Ulta. So these companies are starting to offer it. Amazon, Google, the biggies, even some of the smaller local companies are offering it, and so it's changing slowly. The American Society of Reproductive Medicine, which is I always call it the fertility doctors AMA, they strongly lobby to try to get more insurance coverage for patients, for infertility coverage, and particularly IVF coverage.
Because you have to think 10, 15 years ago. I mean, this is for one cycle, for one treatment, and it's not just the implantation part, but the medication and all of that could be $10,000, $15,000 out of pocket.
Right.
So it does get very expensive. I mean, I know people who have racked up medical bills in the six figures because their insurance did not cover it. Okay, now we want to go back. This was question 8, and it is someone who asked, could we please get some statistics on the frequency of miscarriages? I think most people don't realize how common these are. The science has come a long way, but there's a lot that we still don't know. So miscarriages, what are the statistics on those?
More common than people think, and again, everything that I do is age related, right? And so you take younger patients like 20 to 30 years of age, 20-year-old, maybe 8, 9%, 10% miscarriage rate, slowly increases throughout your 20s. You get up to 30, you're looking 15, 17% chance of miscarriage, 35, 20%, 40, 35 to 40%, 45, 80%. Not a lot of 45-year-olds are able to get pregnant, but the ones that do get pregnant with their own eggs, they have a very high miscarriage rate.
Wow. When it comes to that, now we want to talk about when you are suffering from a miscarriage, people need to know their rights. I am fortunately very lucky that when I went through mine, I was able to tell my boss, and I felt comfortable doing so. Not everybody is in that position where they are able to take a few days or a week off of work if they're going through a miscarriage. Can you help your patients when they're going through something like this so that they are able to get time off? If they aren't able, if they don't feel comfortable telling their boss, listen, this is what's going on, what advice would you have for them?
Fortunately, the majority of times, my staff will come to me and say, I need you to fill out, well, they fill out a lot of the form, but I need you to sign this FMLA form because this patient's struggling with the post-miscarriage, blues, so to speak, and need some time. And so I do find that the majority are very helpful. The ones that are not very helpful, then I become very helpful.
Got it. So, and let's talk about that, Ashley, for the people out there who just don't feel comfortable talking about it at work, but do need that time. What advice would you have for them so that they're able to heal?
Absolutely. Requesting it, usually it takes a physician to sign an FMLA paperwork form.
Yes.
And I oftentimes can help facilitate that too, and provide therapy during the meantime while they have that extra time off from work. But reproductive loss is just as significant as any other loss. But society doesn't always recognize it as that, and it's very silent, and it can really make someone, the beholder, really question what they're experiencing, because the question becomes, well, what am I really grieving? What is a failed embryo transfer? What is an ectopic pregnancy, a chemical pregnancy, a 6-week loss, a 9-week loss? But they're just as significant. And even more so in a way because it's really a loss of the future, and it's something that you have constant reminders about as you move forward in life.
Hope. I do want to end on a hopeful note here. We've had so many people write to us and send us their questions, but people ultimately want to know that there is a community out there to help them. And so I would like for you to just give us your final thoughts on this, if you can, Dr. Neal, just words of hope for people who are watching us.
Well, I think that we have a lot to offer, and there's a lot of treatments available, and I think that if you'll come for evaluation, we can tell you everything that's available. Work with you. I've got a great staff. My nursing staff are very supportive. You know, they're a big part of our practice, and you know, they really interact a lot with the patients, and you know, they're pivotal, I would say, for our practice. But you know, I've seen a lot over the years, and success rates have improved, and I think that couples should feel hope that, you know, we're getting better at what we do. If you look at 30 years ago, the success rates for IVF, for example, are significantly lower than they are today. And so I just feel like we're here to help. You know, I love what I do. And my most favorite thing is to be able to get a couple through the first 12 weeks of pregnancy and send them off to their OB. We call it their graduating, you know, at that point. And so, you know, that's just a special part. And then, of course, I get the next special part is when they come back and show me the baby. And so, you know, I just feel like couples should, you know, trust us, come in and see us, and we'll do the best we can to help you.
Thank you. Ashley?
Yes.
I'll let you have the final say here.
Okay. You know, well, there's no need to do this alone. You know, this is so overwhelming and heartbreaking, but you don't have to do it alone, and there is so much help available. If you're struggling with mental health symptoms, not to suffer in silence, to reach out and to know that there are many people. A great place to point people to would be ASRM's Mental Health Provider Group, where there are therapists trained in this specific area. And you can't go wrong with reaching out for support.
Yeah, you are one of those who specifically focuses on this. Thank you to you both, Dr. Gregory Neal and Ashley Vatswawiak. Thank you so much for joining us here tonight. Two local gems that we have here to answer our questions. And I just wanted to thank all of you for being a part of this conversation. I know it's not easy to talk about. For some reason, there's a lot of shame. There's a lot of stigma associated with infertility and pregnancy loss, but my hope is that tonight you felt less alone in this, and that we were able to answer your questions, because as the name of this says, we don't want you to suffer in silence. There are a lot of local resources. If we could put those up right now, there are 2 local resources where you can get help here. These are just the ones that we know of here in San Antonio, but here's the thing. There are way more national resources where you can go for help if you're struggling with loss, if you're struggling with infertility. We have a list of those for you on our website. And thanks again for allowing us into your homes. Have a wonderful night, and we'll see you tonight on The Night Beat. Let's keep this conversation going. Good night.